Listen, no, we're not doing this.
No, we're going to do this.
That's fine. We're going to do it. All right. So, no, that's not true. More people missed the question last week about the baby with the mask on their face than they missed this question that's in controversy. What does that say? It is a badly worded question. I agree with you 100%. But who remembers the question on your test that talked about the infarction? There was a question on your test that talked about infarction, and what was the answer? An infarction is an occlusion of blood supply
Which
that supplies the heart
with oxygen.
A full occlusion of blood supply that supplies the heart that leads to death of the heart muscle.
Oh. I'm going to be honest with y'all. Okay, that's a dumb question. I would have chose myocardial infarction because it never clarified whether there was death or just like a lack of oxygen. It just says it's stopping oxygen.
Okay.
The stopping
well, we can play devil's
oxygen
advocate.
flow causes death.
Okay. So we can play devil's advocate. Last week, that question stated that you were going to put the mask on the baby's face, right? Well, what if I just sit the mask right here on the baby's face? Exactly. So then does that make that question right or wrong? Okay.
That's not why that's on the patient's face.
So
people in here with an EMS certification that reviewed that question would have picked acute myocardial infarction.
No.
That was a dumb question.
So we're split down the middle because Hannah said she would have picked angina because the question did not have any direct statements about death of the heart tissue. He's a neurologist. He hates the heart. He doesn't count.
What would you have put, Calvin?
He said that he would have picked acute MI.
Thank you.
But he's a neurologist. He hates the heart. Y'all fight about this all the time. Yeah. Yeah. So it's a oddly worded question. So when I read that question, the reason
he didn't see death, so he didn't pick infarction.
There you go. The reason why I would have picked angina is because there was no direct reference in that question about death of any tissue, right? And what did I just tell you, Miss Amanda? What did I just talk about at the beginning of this class about keeping it simple? Right? So when you read the question, and that question in particular, I agree, it is a oddly worded question, and it could go both ways. But for the sake of taking this national registry test, it is a very simply worded question, and so you make it simple. The reason why she's going to pick MI is because she's been all the way up through paramedic school, and she's seen all this stuff, and she's read all this research, and absolutely, there are arguments on both sides of this. But for the purposes of what y'all are going through, a lack of oxygen. I'm going to go sit down now.
You can finish your statement.
No, I'm done.
I'll finish your statement for you. Lack of oxygen is ischemia, not death, even though it leads to death. Anyways, okay. You can finish your statement. Oh, you just turn your mic off? Okay. I see how it is. He did. All right. Is this thing dead? Could you do me a favor?
Maybe one of your MI friends can, though. Mike.
Oh. That's all right. I just need 2 AAA batteries. In the drawer, I got it. Don't worry. Y'all can discuss myocardial infarctions while I'm gone. All right. Sorry.
You can, but they don't give 2 shits about who you are.
What answer did the
if you fail, they feel better. So
What answer did the actual doctor pick?
Oh, that's not really fair. I was teaching him cardiology the other day.
No, you said the think, but it's
Oh.
went over him.
All right. What is cardiac arrest?
A lack of oxygen to the heart.
Oh, he's heated. It stops, right? Cardiac arrest. So there's no electrical movement in the heart, or the heart's not pumping, right? So it can either be an electrical problem or a mechanical problem, right? So you want to do groups of 3? Let's do like random groups of 3. 4. Oh yeah, Garrett's not here. Sorry, Austin. I thought you guys were going to be in. We were going to have CPR dummies. Alyssa, Christian, and Amanda on one. Annie, Joe, and Aaron on another. Jonathan, is he here today? Yeah. Nick's not here today, is he? Yeah, he is. Nick's not here today. Scott, Jonathan, Scott, and Andrew. On another. Okay. So you are dispatched. Do I need one more group? Who taught me how to count? Mike, Isabel, and Jade. Everyone's here? All right. Matt? Not here? Oh, yeah, he's in Austin. Liam? All right. Okay. So you are dispatched to a scene for a 85-year-old female, altered mental status. Who wants to start first? Start at the top of your sheets. BSI scene safe. What's next? Mm-mm. Number of patients. You have 1 patient. Well, actually, you have 4 patients, but you have 1 patient. Yep. MOI, NOI. There's going to be a nature of illness. What's next? ALS. Okay. What else? Consider C-spine. Okay. So you already know it's cardiac arrest, but in this scenario, you don't know it's cardiac arrest yet. You're not even in the house yet. So you walk in, patient's laying on the carpeted floor. Her son's running around. Oh crap! I don't know what to do. Now what? Okay, so you start with your general impression, right? So general impression, female laying on the ground. Maybe, yeah, that's also considering C-spine. All right, what else? Level of responsiveness, AVPU. So how are you going to check for that? Go ahead. All right, she's unresponsive. Now what do you do? ABCs or CABs because she's unresponsive, right? All right, she doesn't have a pulse. She does not have a pulse, but she is breathing at a rate of 2 a minute. What kind of respirations is that? Agonal respirations. All right, Aaron's already started CPR. I like it. Early recognition of CPR.
Is it okay to have the mask on their mouth the whole time, or you got to take it off?
You can have it on there the whole time.
Okay.
Yeah, because you think it's hooked up to oxygen, right?
Okay.
So it's just blowing oxygen in,
What if
whether
it's
you're
not?
breathing. You can, I mean,
It's supposed to be. I know.
yeah, hook it up. If it's not, I mean, they're still probably getting that 21%. All right. Carly, what rate are they compressing at? Yep. How fast are they going? Yeah, what's their rate? Good. I like it. Did everyone hear what Carly said? What's the rate? No. How fast are you compressing? 100 to 120. Good.
One of us will get an AED.
Yeah, one of you guys is bringing in an AED. I like it. What are you looking for whenever you ventilate? Good. What's the depth on an adult? 2 inches. Does everybody have green lights going? All right, don't touch the patient.
Everyone's clear.
Mhm.
We're doing this, we do the 2 breaths, we don't stop compression, right?
You do whenever you don't have an adjunct in or an airway, an advanced airway. You stop to do the 2 breaths. So OPA does not count as an advanced airway. So 30 to 2. I hear. Okay, we got 1 shock. Okay. Good. Awesome. You guys can stop. Did you guys already give a shock? Okay, you can stop. Have you guys already shocked?
We did.
Okay, you guys can stop. Okay, you guys can stop. Okay, you guys can go back to your seats. Turn your AEDs off, go back to your seats. Grandma lived. Good job. Not all the time. If this was Calvin teaching, Grandma would not live. It's true. Everybody dies in real life too, so it's fine. So what was different about that scenario? There's 3. Good. What else? It's kind of different starting from the top of those med sheets, right? Okay. So whenever we do this in real life, what's some other things that we want to try and obtain while we're pumping on somebody's chest? Good. Yeah, history. That's it, right? So we want to know how she got on the ground. What kind of past medical history does she have, right? Okay. One thing I really want to clarify, I'm really clarifying it, because you might see it later, I believe. Who is in charge of saying clear? Who's going to be telling? The guy hitting the button. So whoever's in charge of the defibrillator is the person that's in charge of clearing that patient. Okay, is that clear? That one's on the test, isn't it? Yeah. Okay, good. So our objectives today, we are going to identify the pathophysiology of cardiac arrest. We're going to review assessment of a patient in cardiac arrest. That also includes assessment of a patient post-cardiac arrest. So you got pulses back. Does anybody know what term we use whenever we get pulses back? ROSC. What does that stand for? Yeah. All right. It's all right. Identify what you can do as a provider to improve cardiac arrest survival. So really, this should be burned into your brain. What improves cardiac arrest survival? Early CPR, and were you going to say CPR too? Defibrillation, yeah. So we want to be able to identify a cardiac arrest. Remember that if you walk in and you do your AVPU, they're unresponsive, right? They're unresponsive to pain. You go immediately to pulse instead of, oh, we're going to put them and start bagging them, right? Because what does that delay whenever we do pulse last? Yeah, they're not going to get those early compressions. So our heart, we pump blood with our heart, right? So there's a mechanical part of our heart that actually pumps the blood. And then there's the electrical part of the heart that tells the heart to pump blood, okay? So that electrical stimulation is what gives the heart the contraction of those muscles. Hopefully, in a good, healthy, happy heart, it's all normal, right? We want to feel a regular pulse. There's Sometimes a little irregularities are normal, but if you're feeling like really irregular pulses, that's abnormal, okay? Without oxygenated blood, pumping fails, right? So that statement, what kind of things can cause a cardiac arrest? Mm-hmm. Choking, yeah. Airway problems, yeah. What about respiratory failure? Yeah. Yeah. Pulmonary edema, they're not getting that oxygen. Anything else? Clots, embolisms, yeah, I like it. I like it. What about anaphylaxis? Can that cause cardiac arrest? How does that cause cardiac arrest? It could be a respiratory problem. What did you say? Closing on their way, what did you say? Yeah, lack of oxygen. So if their blood pressure drops because they're in anaphylaxis, that blood's not going to get where it needs to go, right? Causing cardiac arrest. So, mechanical failure of the heart. The heart loses its structure. There's nothing there to tell the heart, or there's nothing telling the heart to pump at that point. So, things that can cause mechanical failure, myocardial infarction. Part of their heart actually dies, stops pumping blood adequately, and death. Chronic hypertension, right? We get that left ventricle gets all fat. And once it gets fat, what can't it fill with? As much blood, right? So just chronic, not being able to take care of that, they're going to have heart problems. Loss of normal heart valve function. So like whenever we're talking about heart valve function, this is like your stenosis. So those hearts, like your arteriosclerosis, your atherosclerosis, stenosis, that gets really hard and it can't function like it's supposed to. So I don't know why they tell this to y'all, but PEA, or pulseless electrical activity, it indicates mechanical failure because there's still electricity going through the heart, right? But there's something wrong with the actual heart muscle, so it's not going to be pumping that blood anymore. So PEA, which you guys technically can't identify on a 4-lead, is indicative of a mechanical failure. And PEA doesn't have to just look like this. There's 100 different forms of PEA. You can have PEA that looks like a normal sinus rhythm. You can have a PEA that looks like VTach. You can have a PEA that looks like sinus tachycardia. So it doesn't have to just look like this. This is just saying that there's electricity in the heart, but the heart's not doing anything about it. And then you have the electrical dysfunction, right? So electrical dysfunction, there's something going on with the electricity, so it's not telling the heart to pump. So a big one is asystole, right? But things that can cause electrical dysfunction is like your MIs can cause it. So anything like a lack of oxygen to those SA nodes and the AV nodes, the little pacemakers of the heart, when they're not getting enough blood, there's nothing for it to conduct at that point because it's not alive, right? So one big one is asystole. We talked about, can you shock, does your defibrillator AD tell you to shock asystole? No. Why? There's nothing to shock, right? So the purpose of shocking a heart whenever we defibrillate and use our AEDs is to take that random electrical activity that it has and try to make it normal. It's trying to shut the heart off and then back on again. So there's something to start. Whereas if this is asystole, there's nothing for the heart, nothing for that shock to restart. It's just doing its own thing. It's off in Netherlands. So here's those nodes that we're talking about. Okay, so remember SA node is our pacemaker node. This is a normal heart rhythm is going to generate from this node right here. And then as it moves down the heart, it comes through here, goes through the AV node, comes down to the ventricles. So like your right and left ventricle is going to be sitting right here. Now you can have where like your sinus nodes, like, see you later, I'm not going to work anymore. So then your pacemaker takes over and it would now be the AV node. That's like a sick heart, right? So like your AFibs, that kind of stuff. So if this is ever blocked off, it's going to go here and it's going to start, this is going to take over. Okay, does that make sense? It kind of is like a railway system. So whenever we talk about dysrhythmias, that's an unusually slow or fast rhythm. Does anybody know what this is on the bottom? That's VFib. Can your defibrillator shock that? Yes. Right? What's this one on the top? VTAC. Good. Can your defibrillator shock that? Yeah. So these heart dysrhythmias, they can lead to sudden cardiac arrest. So there's a few things that can cause you to go into a heart rhythm like this. A big one that you guys probably saw in your book is called commotio cordis. Does anybody remember what that is? So you get punched in the chest or hit in the chest. Usually your scenario is like a 6-year-old or like a young kid gets hit in the chest with a baseball and then they fall over and go into cardiac arrest, right? So that's what sends them into this. Another thing is like electrolyte abnormalities can cause these kinds of things. This, I believe, is a heart in ventricular fibrillation. So a normal heart is going to pump here and then pump here, right? Pump, 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 pump. This is VFib. So this is those little squiggly lines. You think that heart is effectively pumping blood where it needs to go? Not at all, right? So sudden cardiac arrest, defined as a sudden onset of a dysrhythmia leading to death. Acute blunt trauma, that's what we're talking about, that commotio cordis. So it hits right at the perfect right time of your heart depolarizing that it sends them into a weird arrhythmia. If it is caused by the blunt trauma, obviously because it wasn't like a respiratory issue that caused the cardiac arrest, their oxygen levels are going to be pretty normal at the beginning, right? Because they were breathing just fine a second ago and now they're just dead. Then we have your asphyxial. What does asphyxial mean? Yeah, lack of breathing, lack of oxygen. So like your allergic reactions can cause this, respiratory failure. If someone like gets in a car accident, their head's kind of like tilted funny, it can lead to like positional asphyxia. That can lead to cardiac arrest as well. So the heart stopped because it's ischemic, right? It's starting to die because it's not getting the oxygen that it needs. Yeah, quality ventilations are important during CPR. We know this, right? Equal chest rise and fall, normal volumes, all that fun stuff. Why did it do that? I don't remember this. Oh, okay. So this is that agonal breathing that we were talking about, right? So whenever I told you, but she is breathing, and everyone went, she's breathing. They were ready to compress, and they were like, she's breathing. This is an agonal respiration. So I'm going to show you it. The best way I can describe it in a real life person, it looks like you just caught a fish and tossed it onto the dock, and it's sitting there doing that little guppy breathing thing. There's no quality air movement going on here. Oh, it's fuzzy. What does that look like? A seizure? Yeah, I wouldn't be able to do this like if I was an actor. So somebody that with the untrained eye is going to look at that and be like, oh, he's breathing, he's still alive, right? If that was a real patient, do you think they would have a pulse? So their body is dead, their heart is stopped, their brain just doesn't know it yet. So that's what's going on here. They're not effective respirations. It is a primal reflex. Their brainstem's still trying to tell their body to breathe, and there's some of that getting through, but there's no pulse. So that is important to be able to recognize, especially whenever you're like dealing with real people, obviously, because you want to be able to recognize cardiac arrest early. So, effects of cardiac arrest. This is kind of like that whole keep it simple, stupid thing. Heart fails to pump, the blood stops moving, all the cells are robbed, organs start to die, right? Does everybody remember the CPR clock that we learned in CPR class? About how long does it take for brain death? Yeah, 6 to 10 minutes, right? So we want to be able to recognize this really quick. So usually pediatric, we touched on this before in the CPR class, but this should just be an overview. It usually has to do with some kind of respiratory problem whenever we're dealing with pediatric cardiac arrest, most of the time. The other like second highest cause of cardiac arrest in pediatrics is actually going to be like your weird dysrhythmias caused by like genetic problems, which there's genetic problems out there that can cause problems with the heart that have no symptoms before they happen and they can just go down. But if as a first responder, your initial thought should be this is a respiratory problem. So what should we really prioritize in a pediatric cardiac arrest? Airway. So as you're doing your assessment on your patient, right? Whenever we're doing these skill sheets and as we're learning how to run a cardiac arrest in real life, we need to make sure that we're not getting just that tunnel vision. So one good way to kind of avoid this is give people jobs, right? So as a new provider, and when I was a new provider, so my experience, when I walked in on my first cardiac arrest, I don't think I even saw the lady's husband. Like I'm sure he was there. I was told he was there, but I never saw him. I had tunnel vision on the patient. But one thing that really kept me grounded is the paramedic I was with was able to give me direction and say, hey, you go ahead and start compressions. This person start bagging. You put the monitor on. So if you are in that leadership role, and we're going to talk about like whenever you are in a leadership role and we're doing like pit crew CPR, it's really important to kind of assign positions and then try to avoid that tunnel vision. So the more cardiac arrest you run, the more you'll notice on scene, like the weird pill bottles over here, or the empty bottle of alcohol, like those things you'll start to notice more and more. But it is normal to get tunnel vision. Just be aware of it. So on responsiveness, you go directly to the pulse, right? Apnea, being able to identify whenever somebody's not breathing is important. And then the absence of the pulse.
Going back to that cardiac arrest,
Mm-hmm.
no matter which type it is, due to like anaphylaxis or anything, you always start with the A's, whether it's an adult or a child. If it's an anaphylaxis cardiac arrest, you want to get that epi going right away, right?
So as an EMT basic, how
you put it in their arm, just in their hand.
But how would you know that's what it is?
Yeah,
Well,
How do you know?
If you get start pumping the heart, if you get a rhythm, they're just gonna go back anyway. Their airway's
Right,
closed.
you don't know that that's lactic or they have heart attack.
That's true.
At what point do you find out that it's anaphylaxis?
During your history taking. So that's a really good question because per like your protocols, you're not allowed to give epi in cardiac arrest. So if they're to the point of cardiac arrest, you're not giving them that epi. But there is studies where they're taking like 5 milligrams of IM epi and injecting it during the cardiac arrest. So I would say per your book, per textbook, per national registry, you wouldn't be like, oh, this was caused by anaphylaxis, I'm going to give epi now. Does that make sense?
You jump in the car without feeling,
Pretty much, yeah. That's kind of like your ALS intervention, and that's where our epi, because we can give code epi, would come in. So I'd say per the textbook, I will confirm it and make sure that I'm giving you all the right information. But per the textbook, I wouldn't be like, oh, this is suspected anaphylaxis and stab someone in the leg.
So unless they're children, they're right on the ventilation and early
CPR. And oxygenation, yeah.
adults to show up.
The adults, I don't know about that. That is a really good question though, and I'll find out more and let y'all know, because yeah, I've never really thought of that, like test taking wise. So another thing that you might see pre-hospitally is this sudden unexpected infant death syndrome. Very horrible thing. Also referred to as SIDS or SUIDS. So this is pretty much an unknown cause. There are certain things that may be present around that kids that have, like, how would I word this? Like, the possibility of it happening is a lot higher whenever they are not kept in a safe sleeping environment. A lot of pillows, a lot of stuffies, that kind of stuff. So, yeah, co-sleeping. Yeah, co-sleeping is a big one. Yeah, so they don't really know exactly what causes the SIDS, but there's a link there somewhere where the unsafe sleeping habits and the kiddos. So cardiac slowdown, sleep apnea. A lot of parents buy those little owl things that go on the feet that kind of monitor the kids. That's going to be me as a parent, so y'all know. And then if this isn't recognized quickly, that episode of SIDS is going to be fatal, right? Sad day. Unless there's rigor mortis or obvious signs of death, you're still going to provide resuscitation. If that kid is dead and there's nothing else you can do about it, the best thing you can do for the family is not be like, I'm going to work this and try and get him back and take him to the hospital. Don't provide false hope for the family. The best thing you can do in this situation is let them know what's going on, let them know that there's nothing you can do. And there's a lot of like psychological studies. What was that noise? There's a lot of psychological studies where the sooner you let them know, like, yeah, and you use the words dead, like your kid is dead, there's nothing I can do, the sooner they actually start healing, like psychologically. So provide emotional support to the parents, offer to call people. A lot of times on like my obvious deaths or like the cardiac arrest that I've ran or stuff like this, I never know what to do with my hands because I'm like the most awkward person on the planet when it comes to like comforting someone. So I just found like if you ask them, is there anyone I can call for you? Get someone around them that can help provide that. Some families have like pastors, people from the church that they like to call, family members, stuff like that. What is this? All right, what's the first link? Early recognition and calling emergency services. Early CPR, early defib, ALS, and then post-arrest care or in the hospital care. So 5 elements: recognition and activation of the emergency response system, high quality CPR, rapid defibrillation. I think the time frame that you want your first defibrillation to be is within 2 minutes. You want it to be really quick. If it's like something like commotio cordis where they get hit in the chest and they go down, you want it to be even quicker than that. Which in reality is that likely? Probably not. But early rapid defibrillation. Basic and advanced EMS, and then advanced life support and post-arrest care. So this begins before we even get there, right? Because we have to get called at some point. So this is where our mortality rates actually go down, is whenever we start to train the public of early recognition, right? Mikey really harped on this in your guys' CPR class. If you're out teaching the public how to recognize CPR, how to do compressions, even if they don't have a defibrillator, that's going to save anybody more than we ever could, because they're already behind the 8 ball by the time they go down. And if someone witnesses it and they can start it right away, their chances of survival is going to go up significantly. A big thing that's helped with that is the dispatcher, their EMDR codes. They'll talk somebody through how to do CPR over the phone, but that really only does so much, right? If someone doesn't know that you need to let the chest recoil, their chances go down a little bit, that kind of stuff. So CPR moves blood, right? Blood gets to where it needs to go. It oxygenates what it needs to oxygenate. So this is a good little scale of whenever you're getting perfusion, right? So you start that CPR. It takes a second to get up to where everything's being perfused. It takes a few compressions to get up to where that blood's actually getting up into their brain and all to the vital organs, right? Every time you stop CPR, you lose that. And then you have to build it back up again, right? So we want to stop doing the I can't think of words today. What is wrong? I'm having a stroke. Again, you gotta, oh my goodness. I'm gonna reset. You gotta start compressions. Try not to interrupt compressions. There's the words that I was looking for. We talked about the proper positioning of whenever you do CPR. You want to use your hips as a pivot. Keep your arms straight. Don't bend your elbows. Mechanical CPR devices. So we have the Lucas. You guys saw the Lucas. Did everyone in here get to see the Lucas? I know that there was some people, they left early. There's also this other device. This is called like a Zoll Auto Pulse. It looks like this. It's a band that goes around their chest. The big thing with these is you have to do mechanical CPR before you put them on. So when I say mechanical CPR, we have to actually do CPR before we put on like the Auto Pulse or the Lucas. So don't not do compressions because you're like, I have a Lucas out in the truck, and you're running out to the truck and that patient's not getting compressions the whole time. Rapid defibrillation, if you have an AED, obviously if you're out and about in your normal life, ask someone for an AED. On the ambulance, we have an AED. Every ambulance should have one. The sensor recognizes VFib and VTAC, and then the defibrillator pads and all that fun stuff. So whenever we're talking about monophasic and biphasic pads, this is kind of like a visual representation of what we're talking about. So monophasic is very old school. A lot of AEDs in the past were designed to have a monophasic discharge. So what that means is the shock goes from the negative pad to the positive pad. It's just one shock. This is where you get that if you're touching the patient, you'll get shocked. This is why that happens, because it's a monophasic AED. That's going from one point to another. Here's biphasic. So you can see here where the shock's coming up, it's a closed loop system. And so the chances of you getting shocked if the patient's touching metal is not going to happen, right? That's why that guy was able to do compressions and they gave the shock, because it's a biphasic. So one really important thing on this slide is the shock goes from the negative electrode to the positive electrode on a monophasic. All right. So basic life support is the key to cardiac arrest survival. We know that. It's been drilled into your brain. This should just be review. Here's our little triangle of life. This is how we save our patients. So one of the best ways to approach a CPR, a cardiac arrest, is you have multiple people, obviously. So you have more hands to do stuff. Ideal is at least 5 people. So we start doing something called pit crew CPR, and we're going to practice it today. So you have 5 people on a team, and then one person is in charge of everything. One person's doing, 2 people are doing compressions. You're switching back and forth. You have somebody marking down all the stuff that you do, one person running the AED, and then one person on airway. So you get a provider delivering compressions, one provider, they're in charge of the AED. This is perfect world, right? So this isn't going to happen all the time, but and then you get one provider that manages the airway, and then you have a team leader that's literally standing there saying, you do this, you do this, you do this, right? So what does that do for you as a provider, right? We talked about it a little bit earlier. If someone's telling you what to do, it gives you direction. It avoids tunnel vision. Yep, it avoids tunnel vision, right? And it kind of keeps a nice, clean environment, as clean as it's going to be. It does. And so whenever we are working a cardiac arrest as providers, the big thing is anxiety and stress is, what's the word I'm looking for here? Contagious. So if I walk in and everyone's looking to me to save this person, and I walk in and I'm like, oh my gosh, I don't know what to do, they're not going to have faith in me or trust in me to be able to provide good quality care to their family member, right? So this kind of helps negate a lot of that chaos. And then we have our post-arrest care. So whenever we are recognizing ROSC, that's another thing, right? So I believe in your book, it says specifically that ROSC is whenever you'll know that the patient has ROSC whenever they start to breathe on their own again or they start to move. That's not always the case. So there's times that you're working a cardiac arrest and you give the shock, you might see like a little twitch, rarely. So their body just went through a very traumatic event. For them to be able to like start breathing again and look around, those are really good signs. Like, heck yeah, they might have neurologic function back. But a lot of the times you're not going to see that. So just to pre-warn you, I know your book says that. I know there was like, I think a pre-test question that said something along those lines. It's not always that way. So our post-arrest care, whenever we get pulses back on a patient, you now have a whole new patient. So you need to start from the very beginning with your assessment. So you're doing CPR, cool, we got pulses back, awesome. We're going to start at airway. Is their airway good? Do they need to be suctioned? Do they need to be bagged better? Do they have equal chest rise and fall? How's their oxygen saturation? It's probably going to be crap whenever you first get pulses back, but you want to check these things. Circulation, what's the rate, rhythm, and quality of their pulse? Right? You're going to check if they're breathing. Are they breathing on their own? Are they spontaneously breathing? Is it effective breathing? Make sure you always have suction with you on cardiac arrest. I've learned this one the hard way multiple times. And then if you can, within usually about after 5 minutes, you want to obtain that 12 lead. So if you have the capability to do a 12 lead and you have pulses back, you want to get that first 12 lead done really quickly. Yeah. Yeah. No. Well, no. We're just going to say no. You should wait till about 5 minutes after you get pulses back. The compressions is going to affect your reading of your 12 lead, so you're not going to get it. So team-based CPR is ideal. We don't live in a perfect world. Make sure you're taking your standard precautions. Don't spit in the patient's mouth. Don't let them puke in your mouth. That's gross. Use an AED, request ALS if they're available, and then make sure you're hooking your BVM up to oxygen. We want to set them up for success. If you are walking into a patient's house and they're laying on the bed or the couch, you want to make sure that you have them on a hard surface as you're doing compressions. So some people actually have like a CPR board on their ambulance. You can use a backboard, but if you just move them to the ground, that's most ideal, right? This is nice and hard. Airway adjuncts are big. We know that. We all went over how to put them in on Tuesday. Here's our coordinated resuscitation team. So my advice to everybody in this room is before, if you know for sure you're going out on a cardiac arrest, on any call really, but especially cardiac arrests, you should be talking with your partner about whose role is what. So like if I was riding with Hannah and we got toned out to a cardiac arrest, I would talk with her before we even got on scene. Like, hey, I'll take the monitor if you want to take over the airway. So I'll do compressions and monitor. This should be set before you get there. It's not always going to play out like that, right? But as long as you have a good game plan before you walk in, that's also going to really help with your tunnel vision. Make sure you're doing practices as like a group. So like I know the MIND group, if you guys can set up like scenarios and do CPR and kind of give everybody a role. So if something like that happens, everybody already knows their role before they even get paged out to it. So this is that pit crew CPR that we were talking about. You have someone up here doing airway. You have 2 people CPR, monitor defib, medications, and then team leader. So ideally 6. Usually the monitor and medications kind of get put into one person. You should have switching roles with your CPR, right? Obviously, in a perfect world, we would love to have 5 people with hands all the time. But if you need to condense this down into 2 or 3 people, it is possible, but this is ideal. So, ensure the key elements of cardiac arrest care are provided. So good compressions, early defibrillation, good ventilation, insert your airway adjuncts. Anytime you're bagging somebody, unless they have a gag reflex or something, you should be putting an adjunct in your patient. You went through this. Try not to move the patient. So there's a lot of studies done, especially with pediatric patients, that as we're working the cardiac arrest, you really shouldn't move them for the first like 15, 20 minutes. You should be working the code. Obviously, sometimes we need to grab them out of their bed and scoot them into the living room. That's another thing, but try not to move the patient too much. After you get pulses back, try not to move them again for another 5 minutes. Their body's going through a lot. They just built up a lot of that lactic acid. Their heart's very sensitive because it was just dead a second ago. So give them a second to kind of woo-saw and then start moving them. Bless you. We're going to use our AED. Everybody knows how to use an AED. Here's your flow chart for the AED. You guys should already know this. Do I plug it in before or after I put the pads on the patient's chest? The pads after, right? Because if I plug them in and I'm moving the pads around, it's going to recognize whatever I'm moving around. So put pads on, plug into the AED. Yeah. That would. Yeah. So if they have an organized rhythm, whereas PEA would look like an organized rhythm. So the only two that it identifies is VFib and VTAC to shock. So if you're doing compressions while it's analyzing, it's going to analyze that as VFib or VTAC, so it would shock. But to not shock, it's either a organized rhythm of any sort, whether it's PEA or they have a pulse back, or it's asystole. And then how often after you deliver the shock should you start compressions? Immediately. Yep. Good job. So focus on high quality teamwork. Depending on your protocols where you work, where Chaz and I used to work as an AEMT truck, if we worked a cardiac arrest, we had to transport them unless we had a paramedic on scene with us. So make sure you're following your local protocols. Out here, we work the patients on scene until we get a rhythm back. So focus on the high quality teamwork, give everybody a role, make sure you're communicating well. That is one thing I think we can work on, watching you guys work in groups of 3. I know that was like new to y'all. If we can communicate really clearly, give people those roles and say, hey, you go ahead and do CPR. Or if you're doing CPR, hey, I'm getting tired. I'm going to need to switch out on this next pulse check. Okay. If you're talking to the patient's family, be respectful. Try and get a patient history if you can. Look around the scene for those clues. Do they have any certain medications they're on? Do they have discharge paperwork? Do they have a list stuck to their fridge of all their medications, allergies, DNR forms, that kind of stuff? So say I walk in and grandma's on the floor and the family's running around all frantic and they say, but she has a DNR. What do I do? Yeah, you continue to do CPR, basic life support, until you actually see the DNR. The family watching your resuscitation, that's a big one. So whenever I first started, the paramedics that I worked with would not let the families in the room as we did resuscitation. I talked about it a little bit earlier about like starting that grieving process. This also helps the family. They're watching you do everything that you can to save their family member. That's going to help them come to terms like they did everything that they could, right? So if the family is not like hysterical and actually in your way, if they want to stay in the room, I would recommend having them stay in the room and watch you. Some family members might say, no, I don't want to watch that. That's fine too, right? But give them that option because that's a big part of their grieving process. So post-arrest care, what's the first thing we do as soon as we get pulses back? Yeah. Yep, it's a new patient. And then what if they lose pulses again? start all over, CPR again, right? You should be checking for a pulse every 30 seconds. That is really hopeful thinking because as you're moving the patient, unless you have somebody there like on the pulse, sometimes you go longer than 30 seconds, but try to just really monitor that patient. Their chances of rearrest is pretty high. If you are in the back and you witness a cardiac arrest or the patient rearrests and the vehicle is moving and your AED needs to do AED things, you need to stop the vehicle. Why is that? Yeah, it's going to read that road noise. I'm not having a stroke, I swear. So, yep, continue. Follow your protocols. Once you start CPR, when's the acceptable time to stop CPR? Too tired to continue. And there's another one. Doctor says you can stop, and then there's one more. You get a pulse back. Good. So if you get a pulse back, if someone shows up and says, hey, I can take over for you, obviously you can stop there. If you are absolutely too exhausted to continue, please don't do like a half a round of CPR right after calling 911 and the ambulance is 4 minutes out and I walk in and you're looking at me like I'm too tired. Please don't do that. But if you are too exhausted, you can. And then another thing is if you have a paramedic on scene with you, they can call a doctor. Sometimes it depends on the protocol. If it's within 20 minutes, we've given all the meds that we can give. We've crossed off all the H's and T's or the causes of cardiac arrest that are reversible. A paramedic can call the doctor and say, hey, we did all this. The doctor says, okay, time of death. So paramedic cannot be working it and just say, all right, time of death, I'm done. They need to call medical control and talk to them and get orders. This is that big tell them that they're dead kind of thing. Try to avoid using words like they've passed on or they're no longer with us because their subconscious is not going to accept that as they died. So use those straightforward words. It sucks. It's uncomfortable. It doesn't get easier whenever you're in this position, but make sure you are using the words they have died. Don't suggest that you know how they feel. Even though you feel like you might know how they feel, don't use that. That's just going to make people angry. It's okay to cry. Take time and be patient. Like I said, contacting anybody that might be a person of comfort to them can always be helpful. That's a big one. Okay. If you are providing like AED care before the paramedics have arrived or ALS has arrived or anybody else or before you get into the ER for whatever reason, let them know how many defibrillations you have done and say you're coming to take over another patient. Say you got called to a grocery store and they have an AED out. Ask them how many shocks they have given. And then if you're walking in as they're getting ready to shock, let them do their thing before you take over. Let them give that last shock. Okay. These AEDs that are on like the walls in some of these offices and stores and stuff, you can actually take them to the hospital. They can download the data and kind of see what they're working with there. If you're in the ambulance, this is another thing. Obviously, we're going to stop it if our AED is analyzing the rhythm. If you're 12 seconds from the hospital, I wouldn't be like, stop right here, stop right here. But I would pull up and then let it do its thing. Yeah, we talked about if you witness them go into cardiac arrest, deploy the AED. I like how they say deploy the AED, like it's tactical. Some other special circumstances, so hypothermia, they teach that you can attempt defibrillation once and then don't do it again until their body temperature is above 86 degrees. It's 86, yeah. So the reason behind that they're not conducting as good of energy, I believe is what I read. The big thing, and you'll hear this like everywhere, EMS, they're not dead until they are warm and dead. So they need to get back up to normal body temperature before they can be called. Now, if I walk up and they're like hard as a rock, I'm not even going to start trying, right? So keep that in mind. Use judgment, but they're not dead until they are warm and dead. Does anybody know what movie this is from? I love that movie. All right, submersion. Do we shock them while they're still in the water? How do you apply pads to a wet chest? Dry it off and put it on. A big thing with drowning, we talked about this a little bit. I don't know who was all out there while we were talking about it, but drowning causes a laryngospasm. So that's like a little closure in our airway. So things you want to do before you start the whole resuscitation process is a lot of times you have to give it 1 or 2 really forceful breaths, and then you start doing everything else. That's why they're talking about being aggressive with the airway management. This is where you also see like a lot of that frothy sputum. If someone has drowned, their lungs are full of fluids, and so their airways can be really hard to manage. So make sure you're using those PEEP valves. You should be using PEEP valves on cardiac arrest anyway, but make sure you have one in a submersion. What do I do if I find a medication patch? Yeah, don't shock over it. You can take it off, wipe it off, and just don't put it directly over it. What is this? It's kind of hard to see, but what is that? Yeah, it's a pacemaker. What do I do with my defib pads if I see a pacemaker? Yeah, keep it away. I believe test answers are a couple inches away. What about this? What is this? Yeah, what does it do? Yeah, it's their pulse, right? So it's a left ventricular assist device. So what it is their heart, they've gone into heart failure for whatever reason. They get this device implanted into their left ventricle, and it actually pumps their blood for them. So these patients are particularly special because a lot of them don't have a pulse. There is like one brand out there that they actually do have a pulse. I've never seen it. All the LVAD patients I've ever had have no pulse. So what if they're unresponsive laying on the ground? I see this LVAD sticking out at me and I go to feel a pulse. How do I know if they are alive or not? You can check their breathing. Yeah. So any signs of cyanosis, unresponsiveness, not breathing, you need to start CPR. A lot of times with the LVADs, they have phone numbers on them. So you can call the LVAD center wherever they got it, and they will give you direction on what to do. But you start CPR until you can get a hold of them, right? Some of them say don't do CPR on LVAD patients. If you're in an area with a lot of LVADs, try getting a list of like the hospitals around that give LVADs and their CPR requirements, because that does change. So there's certain hospitals that will say like within the first 3 months of them getting the LVAD, don't do CPR, but after that, like they're free game, right? So these can be weird. Some troubleshooting things on LVADs. If there's something wrong with the power source, you will know. It's going to scream at you. It beeps, and it's the most annoying beep ever. This thing has 2 batteries on it, and so they have like a little fanny pack that they wear. They have 2 batteries on it, so if one dies, you have a backup that's already in there. And then usually they carry batteries with them. They can plug directly straight into the wall. If you go to listen where the LVAD is, that's one good way to troubleshoot. If they're like unconscious, unresponsive, or even if they're having problems like chest pain, those kind of things, and you listen, you should hear like a whirring, like a mechanical whirring noise. If it ever sounds like somebody took a handful of dimes and put it in a blender and turned it on, you have problems. You need to go to the hospital, preferably to the hospital where they got their LVAD put in. I don't think we have any LVAD patients around here. But
the closest one was, I think 5 years ago, they had one out of Winnemucca. And this is just a bridge, right? This is like to death or to a heart transplant. They're not living 40 years with an LVAD on. And then it used to be that to have an LVAD, you had to live within like 80 miles of the facility to put it in. Those restrictions got lifted. We had one in Winnemucca several years ago.
Yeah. So this is like their last resort before a heart transplant. Some patients are like, I'd rather just have an LVAD than a heart transplant because their life's a little bit easier afterwards. Because you think these patients before getting this have been very sick, right? They're cardiac or congestive heart failure. There's the word. God dang. It's going to be the same as like with somebody without an LVAD. They're still going to be breathing. Their lungs are usually fine. You might start to see like if their LVAD's really failing. Some big things that we see with LVAD patients is an infection in that line. So if I go back, you can see like right here, this cord comes up, their drive line comes up and goes into their belly. And they'll get infections like right around this area. And that infection actually follows this line all the way up into their heart. And so that's like Chaz had a really bad LVAD patient. That was her problem. She was septic because of that. But their respiratory rate, you're still going to count it. It's still going to be normal. They're still going to breathe like they're supposed to be breathing most of the time, unless it's like a specific, like if you had an LVAD and a trach at the same time, that'd be different. But other than that, it's, they look very scary. So use your resources. There's phone numbers on there. Use the phone numbers. Yeah, pretty much. So it kind of depends on what they're calling for, right? Because if they call for chest pain or dizziness or fainting, you want to do really good assessments on these patients because you don't get like that pulse. You can run a 12 lead on somebody with an LVAD. It'll still show up. You'll see a little bit of like 12 lead or LVAD artifact on there. So treat your symptoms. So if somebody calls, treat them for their symptoms that they're calling for. So any other questions about LVAD? They're kind of scary. I had a really good friend that actually got one. That's why I know a little bit about it, but they still freak me out. So Chaz had a good one. Like, yeah, they get sick. All right. So if you guys want to take a 5-minute break and then we'll come back, we'll do pit crew CPR and you guys can practice giving everybody a job. Yeah.
So with the peacemakers, so
Mm-hmm.
will they, have you ever like had a situation to where it like doesn't go out all the way? So like the peacemaker's like trying to restart, like you see the body like flopping like a fish.
So like with the cardiac pacemaker and the implanted defibrillator, I've seen where their implanted defibrillator just like randomly goes off, like there's something wrong with it. So it'll just start like defibrillating them.
So would you put like a AED on it, or would you just like let it restart by itself? Or?
So what I would do in that, if they're awake talking to me, like I've had where they're talking to me and they're like, my implanted defibrillator keeps going off, I'm going to get a 4 lead and a 12 lead. That's like the big thing. You want to see what their heart's doing underneath. Even if you can't interpret it, if you could send it to somebody, because it might be that they're going into a dysrhythmia, or it could be that their defibrillator is malfunctioning. Same thing with the pacemaker. So the pacemaker can also malfunction and like send them into all sorts of crazy heart rhythms.
So like if they're flopping like a fish though, like
It's
and you know that the pacemaker is like is disrupting, would they be on and try to restart that pacemaker, or would you just let the pacemaker try to restart itself?
That would be something that you would put the AED pads on. You would not shock it.
You would wait till they go out.
Yeah, you would wait until they go out and then do it. Some places carry big magnets and they're like huge. And you actually, if you know that the defibrillator is like malfunctioning, you can take that magnet and set it right over their heart and then it actually deactivates it. So we carried them in Idaho, but
Did you ever have to do that?
yeah.
Where do you get the magnets from?
I don't know where they got them from. They're stuck to our walls, so. No.
Going to tinkle.
All right. Can't electric shock cause arrest? Sorry, let me go through these. All right. Perfect. Yeah, I was gonna call Kim or text her today. I think Chaz has already talked to her about it. Electric shock cause arrest. Yes, electric shock can cause arrest, cause an electrical disturbance, leading to cardiac arrest. And you can use a Lucas with an AED, so it's actually preferred that you throw the AED pads on before you put the Lucas on, so they're put in appropriately. Sorry, I just saw all your messages.
Are we all going together? No.
We went to the same high school.
Biphasic. Mm-hmm. Yes. Nice. I like it. That's funny.
Retire next year, huh?
She said, yeah, you're trying to do a career.
You squeezed them out. I told you when the third one came out. You want to give away. I get one of these. And the middle one for sure is going to cost you a bunch of lawyer fees.
She already has rate one. I want the middle.
That's why. See, she's always acting like a thug. She's kind of a dick.
That's what I'm saying, bro.
No, I'm gonna send her.
Yeah.
Onyx
please
was
do.
in love with
If you think Onyx wants that headache, dude.
Don't love it.
Dude. Reese, don't. She don't think no. Don't listen. Don't do that.
No.
Running
Reese and
around-
Onyx, I see you now.
We're running around with knives in her mouth. Dude. You take the knife like,
No.
okay, put that.
So how do you want to do the cahoots with them? So I found one, but it's David Ellis's. So I just don't know how. Did you want to do it with everybody or just? It's 22 and 23. So it's, oh, for the test? Yeah, it's just 21. So yeah, cahoots. All right, let me ask them. Yeah, no problem.
Don't stop with the idea. Dude, are you kidding me? Hell no, dude.
I'm gonna tell you, after 3, it's not that big, I mean, that's fine.
Yeah, someone said that after 2 and they lied.
It's after 3, they all kind of put together. You bring it to the R, it's like, middle one, big one, small one, stop it.
Listen, I'm already looking. I'm retiring. We're buying a fifth wheel, and we're just gonna travel. I'm gonna find a job where I just can work
You're gonna put them in
online.
a fifth wheel, all of you.
Damn right I
That's
am.
a great idea.
Damn right.
Buy one of those 2-story.
Hell no, that's just bro. I work in EMS.
Just like a little 12-foot.
Yeah, a little 12-foot, dude.
Little like Mickey Mouse camper.
Yeah, 12 inches, dude.
3 kids, yeah, sleep in one bed on the floor next to
Listen,
each
I'm a minimalist. I don't need a lot. Place to pee, food in my belly.
They're on the online people are like the roots in the background while we just make it to do because I feel bad. You're gonna hear cahoots in the background.
Oh, you got that.
Cahoots doesn't work on my phone usually because I can see it on the board and it's can't be full. Okay.
Just switch off the board and go to the Kahoot, Miranda. We can see you on our side.
Okay. Groups of 5. Do you think it would be easier if we did one like out in the living room and one in here, just so it's not so? Okay. Yeah.
Hey Becca, will you kill your mic for me?
Yeah.
Check. Okay. All right, dude. Who did JD Vance? Y'all need to chill out with these politics taking your whole life. You need to chill out with the politics taking your whole life over. That's just my voice. That's just my voice. That's not what I wanted. Nah, bro. I'm square, bro. I got 3 great little girls. One's a thug. One's got a soft heart. One can't seem to break the breast. Everybody. All right, that looks like it's everybody, huh? Okay. Give me a thumbs up if you guys are ready to start. All right, I'm telling you right now, my prediction, I'm putting my eggs in Team Austin's basket. We're starting. Oh, here we go. Not a link in the chain of survival. Ooh. Ooh. Right? Early ALS is in the chain of survival, as well as rapid defibrillation and early CPR. Okay, monthly training is not. Who is me, dude? Good job, me. Oh, you're not in this, bro.
I am. I'm not doing this. I'm on that out. So.
Oh, okay.
It is me.
1 minute to discuss who picked what role.
One rescue or CPR on an infant is performed with.
Okay? So as we run this, we're gonna try and go off of our sheet. And we're gonna go off of our sheet, right? Yeah.
I don't mind thumb and circling technique. 2 fingers is the preferred. Good job.
He's fine. He's fine. Then your initial general impression. You walk in.
Ooh.
He's laying on the
Ooh.
ground. Yep.
Got some thinking going on. Okay, so your radial pulse is going to be less prominent than your carotid, right? Your peripheral pulses are getting less pressure than your central pulses, right? Which your central pulses are going to be your carotid and your femoral. That is your best shot at feeling a pulse, unless it's a pediatric patient. If it's not pediatric or pediatrics, you're going to check a brachial. If not, it's carotid or femoral. It's a central pulse. So if you don't know whether you feel it or not, fuck it. Start compressions. It's better to start them and be wrong than start them late. Do not touch the patient. Analyzing heart rhythm. Shock advised. Do not touch the patient. Everyone clear. 20. Press the button.
Clear the patient.
Think about your chain of survival.
Right? Like it. Then down. And down. Then hold.
Okay, right? Early defibrillation is key to survival. You want to get it on as soon as possible. I'm really glad nobody put medical director or DNR. Think of the chain of survival again.
So your ALS is 30 minutes out. Actually, looks like 10 minutes out. Or 10 minutes out. What are some things you want to start thinking about right now?
Let's go.
Right? How many shots have y'all given? Okay. Do you know anything about this patient?
Oof, that's a tough one too. I'm not mad at that answer, but perform CPR while your partner retrieves the AED. Remember, we have that chest compression fraction time. The longer you're on the chest, the more chance they have of surviving. So if you have 2 people, someone jumps on the chest and starts compressions right away.
Yeah, he was supposed to have a pacemaker implanted, but he's too stubborn.
Good job. 30-2. 30-2.
Okay. So ALS just got here.
Ooh, let's go. Good job, right? If we think about our anatomy, we have two pipes that come through here, right? One is your esophagus and one is your trachea. One is going to the abdomen, one is going to the lungs. Air doesn't know the difference. So if you're ventilating too hard, you're going to push air down both. That's why when we teach bag mouth ventilation, it's a gentle squeeze, couple fingers, even, and then we're off over 1 second apiece. Good job, everybody. Pink Pony Club, I'm gonna keep on dancing. Pink. Good job. I like quick answers. I like that everybody knows it's like the back of their hand, right? 100 to 120. This will be on your national registry exam over and over. Good.
Okay.
5.
So what's different about having one?
Yeah.
What is one thing y'all always take away from this scenario?
Okay. 2 to 3 inches, right? 2 to 3 inches.
Okay. Yeah, I like it. What about getting like
2 to 3. Oh, it's 2 to 2.5.
Yeah.
2 to 2.5.
But the other one was way too short, right? The other one was like 11/16 or some shit. To rescue on an infant requires a compression to ventilation ratio of to rescuer CPR infant. To rescuer CPR infant. All right. So where's Hannah? Hannah, what's your little saying?
If it's just you, 30, wait, if it's just you, no matter who, 30.
Okay. So Hannah McCafferty has a neat little saying, right? And if it's just you, no matter who, 30-2. Pediatrics and infants, as soon as we have two people, we are switching to 15-2. Now remember, this isn't just a random number we came up with to do that. We're doing that because kids don't die from having bad hearts. They die from not being able to breathe. So we're cutting the compressions in half and essentially doubling their ventilation. Okay.
Okay. So what do you do for your
Ooh, 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 ooh. Okay. Remember, the only two shockable rhythms by an AED is ventricular fibrillation and ventricular tachycardia. It won't shock a sinus rhythm because that means that the heart is functioning, right? Your sinoatrial node is where a normal heartbeat starts. So it will not, it'll recognize that as a normal rhythm and it will not shock it. Your only two shockable rhythms are ventricular fibrillation and ventricular tachycardia.
All right.
All right. So you are called to, oh yeah.
Medication patches.
So you're dispatched to a
Okay.
32-year-old male who's out and about. Someone said they just.
Yeah, this is one of those questions where there's kind of two right answers. If you can remove it, if you can readily remove it, you can do that. There's also nothing wrong with leaving the patch in place and putting it elsewhere. I think it all depends on the medication patch, but honestly, if you do either one of these, I'm not going to be mad at you. Good job, right? When it's analyzing, we can't touch because we don't want to interfere with the AED's analyzation, right? It could give you a false reading and lead to maybe a unnecessary shock or not shock at all, right? If it picks up that you have an organized rhythm for some reason, it's not going to shock them when they might need it. So good job. Make sure no one is touching the patient. Ooh, your patient begins moving after the AD delivers a shot. Okay, right? As soon as we give that shock, if that person is moving, that means they have some kind of perfusion going somewhere. Okay? We need to reassess a pulse right away. If they start moving, if they start breathing, if they start opening their eyes, anything like that, those are indicators that you have pulses back on a patient. You've got ROSC, which is return of spontaneous circulation. You need to reassess a pulse at that time. Oh. Ooh. Okay, right? EMS and check for a pulse is where we want to go because that's who we are as people, right? We're type A personalities. We're here to help. But we need to, before we do anything else, is make sure that scene is safe for you to be in. Because if it's not, whatever killed them can kill you. I'll give you guys an example of this that I messed up on. We had a guy that died from carbon monoxide poisoning. He barricaded his garage. When we went in there, and this is a learning that I'm going to give you guys to not do the same thing I did. I went in to retrieve him. I took one breath and almost passed out, right? So if the scene is not safe for you to be there, instead of saving their life, you're going to cost your own. So always, always, always make sure the scene is safe. It's kind of a shit question, but. So, yeah, patient has an implanted pacemaker, right? We're going to have to alter our placement. However, I'm also, it's tough because it says the way you use an AED, that can be interpreted a lot of ways. Honestly, patient is under 8 years old is not a bad answer because we do AP, anterior, posterior pad placements on pediatrics. Not the worst answer, but definitely an implanted pacemaker is going to change the way we use it. Hey, Liz, I'm teaching class. Can I call you back? Yeah. Thank you so much. Bye. Sorry, I'm a popular man. People just keep calling me. Okay, you don't have AED pads and you're coding a PED. What are we doing? Yeah, fuck yeah. Use adult pads, right? At the end of the day, it's better to overshock them than not shock them at all. Good job. No dispatch in the world is going to deliver you PD pads. I mean, you can call to have another unit bring it, but you don't want to delay that shock, right? Remember, we want high quality compressions and early defibrillation ASAP. Seconds matter. Time is tissue. The longer this goes on in cardiac arrest, the less chance they have. Remember, every minute that goes by, knock off 10% survivability right out of the gate. Damn, there's 43 of these questions. This is a big one.
Oh, crap. Well, that's kind of a trick question. It went into the pool of water, but.
Okay.
How deep
Okay.
is the pool of water?
This is right because it doesn't specify how deep the pool of water is. So I tossed this question out, but I'm gonna say, right, if they're completely submerged, you can't shock. If they're just wet and have a little bit of water around them, dry them off and hit them. Submerging, right? They can't be submerged in water. The chamber of the heart that pumps deoxygenated blood to the lungs. Right ventricle. Good. Vessels that supply the heart with oxygenated blood are called coronary arteries. Okay, jaw pain is a sign, especially in men, right? Women can have an array of things: anxiety, abdominal pain, difficulty breathing, feeling weak. Women are a crapshoot. We don't do enough research on women. We do them a disservice by doing this, but all the research is based around the population that dies from heart attacks the most, which is men. Women can have a lot. Jaw pain is a telltale sign in a man. Jaw pain is a telltale sign in a man that they are suffering from a myocardial infarction. Fever, I want you to correlate fever with one thing: infection. Fever equals infection. Fever equals infection. I'm going to say it one more time. Fever, infection. Ooh, So it's angina pectoris, right? That's like the textbook definition of angina pectoris. So When an artery to the muscle is completely blocked and causes some heart muscle to die,
Yeah, it is, but I need to go on, but I should actually look.
yep, myocardial infarction, right? Completely blocked and causes some heart muscle to die is a myocardial infarction, right? Infarction is correlated to death. Ischemia is correlating to dying. Okay? Which of the following is not a sign of CHF? Good, right? They can have JVD. That blood flow, because the heart is not pumping adequately, is backing up to places it shouldn't. When you have right-sided heart failure, the first place you're going to see it is in the feet. And difficulty breathing with congestive heart failure is because the fluid is starting to back into the lungs, making it hard to breathe, right? Good.
And you're like, not me, I'm ready, right? Yeah. You like that one?
I like this area.
Okay, so this is the AHA recommendation, and this is a fairly new development. So they're saying this because if you give someone too much oxygen, which there is such a thing of having too much oxygen, it actually causes their vessels to constrict. So if those vessels get smaller and you're already having a heart attack, it's going to make that blood harder to pass through that blockage and get to where it needs to go. Ooh, you either know it or you don't. Left atria to the right, left ventricle. Think about this. It's left to left and it's right to right. They don't crisscross.
Anybody have any questions? Ratio,
Yep, right. The heart is failing. It can no longer keep up with the demands of the body. So it can't get blood where it needs to go, and it starts to back up in the opposite direction, going into the legs for right-sided heart failure, the lungs for left-sided, and when the entirety of the heart starts to fail, it backs into both. (28) Stable angina. Stable angina. Yeah, so for stable angina, once they start resting and those arteries start relaxing, they'll feel better because they're getting blood flow back to the heart. Whoa. Yeah. Yeah. I like to do that. That's my wife. Classic heart attack symptoms. Right. 56-year-old white male. That is your predominant class of people who have heart attacks. Right. So when you're reading this question, as soon as you see diabetic or female, throw that shit out. Right. Throw it out right away because they never have, not never, but they don't have classic signs. Remember, we just got done talking about how all the studies come through males, and that's why, right, chest pain is attributed to a heart attack, but females can have a myriad of God knows anything, and it can be a heart attack. This is important. We need to know what the drugs we give do. If you don't, you have no business giving them. Good. Dilates the blood vessels. I like it. I like it. Goes back to the same thing I just said, right? If we know that it dilates, short of breath. SOB means short of breath. Yeah, right. If they're taking some ED pills, their vessels are already dilated. Fun fact, that's how that works, right? It dilates your vessels so you can get more blood flow down there. And if your vessels are already dilated, we don't need to dilate them more. $11 more questions. Who's going to come out on top? Have we gone through shock yet and all the different shock? Okay. Hypovolemic, cardiogenic, distributive, and obstructive. Guys, shock and these words can be broken down into these categories. And if you correlate these with either a pump, a pipe, or a fluid issue, that can help you discern what kind of shock it is. Is my pump failing? Is my heart failing and cardiogenic, right? Hypovolemic, do I not have enough blood or volume? Is it a fluid issue? Distributive and obstructive, right? Is something wrong with my pipes, my vessels, that's not allowing me to, transport the blood where it needs to go? So you have like anaphylactic, septic, neurogenic, and hemorrhagic down here. Those are all subsets of those categories. So real quick, an anaphylactic, it's a pipe issue, right? Your pipes are dilating, your vessels are becoming leaky. It can no longer take that. Hemorrhagic shock, well, what is it? Someone's bleeding out. That is now a fluid issue or a hypovolemia issue. I can go on for days about shock, but I'm going to try to punch you guys through this and get you out on time. Austin, climbing to the top. 10 more questions. 10 more questions. We just talked about shocks. Vomiting for 3 days. Vomiting for 3 days. Hypovolemic, right? They have no fluid. They have no fluid. They puked it all up. Which of the following describes hypovolemic shock? For the love of God, we just talked about this. I want to see 5 for 5. What is it? Good. So a lack of tone in the vessels would be a distributive shock. But it is hypovolemia, right? Break that word down. Hypo mean low, volemia, volume. They don't have blood volume. Oh, multiple gunshots to his chest and is breathing 4 times per minute. You first. Ooh, we got a myriad of answers. So I'm just telling you right now, if you run up on somebody, they've been shot a bunch of times, and they're breathing at 4 times a minute, 4 times a minute is not enough to sustain life. If you take the time to alert a trauma team, I'm going to tell you right now, you're going to call the University of Utah, be like, I'm alerting the trauma team. They're going to be like, where are you? I'm going to be like, Battle Mountain. They're going to be like, what the fuck are you calling me for? Right? Like, we'll see you in 3.5 hours if you're lucky, right? If they're breathing at 4 times a minute, not enough to sustain life, we need to assist them with bag valve mask ventilation. I guess Renown is the nearest trauma team. They're going to tell you the same, probably verbatim. Cardiogenic shock. I can see where people got 2. I'm not super mad at 2, but this is a pump problem, right? This is a pump issue. That engine is not working effectively enough to get the fluids where they need to go. Good, right? What these guys are saying in a lot of words is this person is in shock. How are we going to treat this shock? Right? That's all this question is asking in a myriad of words. Okay. 3 and 3. So let's talk about this a little bit. They're in septic shock, which is a system-wide infection. Okay. This doesn't mean that they don't have enough volume in hypovolemia. It means that their pipes or their vessels are infected and have started to expand and gotten big. Now think of a garden hose, right? If you're pushing water through a garden hose at the same PSI, but then you get a garden hose that's 4 times the diameter, that water is not going to flow the same. Okay? Septic shock is the same as anaphylactic shock in the way that it's a distributive shock. Those vessels are getting permeable, they're getting leaky, and they're expanding. Now you don't have the pressure behind those vessels to get that fluid where it needs to go. So in septic shock, it's not a hypovolemia issue. They have, why are you laughing, Lake? Why are you laughing at my instructing over here, dude? This is dick, dude. Fuck Montana Western. Hypovolemic shock. Their volume is not the problem. It's the method of delivery. You're out of your prime. Quit it. Okay, good. It's obstructive, right? It's obstructing. It's a roadblock in the delivery. Guys, feel free to step in at any time. I'm not doing so hot up here. And you guys are going to go over anaphylaxis next week. So if you get this one wrong right now, it's okay. Good, right? Blood vessels dilate uncontrollably. That, just so you guys have some tidbits when you go to next week, that's from a histamine response. Your body dumps histamine to fight the infection. Turns out it dumps too much. Your vessels go boop, boop. Hit them with the boop. Good. Compensated, right? If your blood vessels are still constricting and maintaining a blood pressure, which maintaining a blood pressure just means we are still getting oxygen and blood to our vital organs, you're compensating. When you stop that, now you are in decompensating. You're not fighting it anymore. You're not fighting to keep yourself alive. Ooh, 2 questions. Headache. Last question. Good. We're not giving our patients water. JD Vance in 3. Good, good. Good, good. All right, guys, thanks for playing Kahoot with me today. Yeah, another chance to come back to class. My name is Mike Harris. I'll be here for probably Monday through Saturday for the rest of my life. Not Sundays. I go to church on Sundays. Can I cut them? All right, guys, that's all for class today. Thank you very much for participating. You guys are doing great, and we look forward to the future. No, you weren't. No fucking life.
It's, my first one on this and my second one next Sunday. I don't need it on Saturday. I was thinking, like, when we're sitting here, I can get on my Sunday. I think put hours in it, all of that, or.
That would be a question.
Okay. Okay.
Thank you.
one of us is going to be fighting on that.
Oh, well, they're not, nobody else is.
Yeah.
I can do it whenever, I just.
Okay, yeah, I would ask.
Okay.